Hello and welcome back to today's session about post-cardiac arrest management. And before I start the visitation video of today, I'm happy to introduce today's lecturer, Alexander Kersten.
Hello, thanks for joining us.
I think he will have his presentation after the video.
Yep, exactly.
Julia, I think there's no sound with the video right now.
Yes, I heard it. I try to.
Transported to our
Working.
That was working right now.
It was working. Okay, perfect.
cardiac catheter lab. Angiography revealed a left anterior descendens arterial occlusion that was successfully treated with a balloon angioplasty and stent placement. After the revascularization, the patient was admitted to the
I think we will start
Hello,
at the
and
beginning.
welcome again to the ICU. We are here on day 3 of Mr. Miller's stay. The 55-year-old patient had a cardiac arrest with a no-flow time of probably 10 minutes. Out of hospital, the paramedics started with a resuscitation. They delivered 3 shocks and gained a ROSC after 8 minutes. The patient was then transported to our cardiac catheter lab. Angiography revealed a left anterior descendens arterial occlusion that was successfully treated with a balloon angioplasty and stent placement. After the revascularization, the patient was admitted to ICU. We treated the patient with a post-cardiac arrest protocol with targeted temperature management, first 24 hours with 34 degrees, then we started the rewarming with 0.5 degrees Celsius per hour. The rewarming was finished, the cool guard, who was for the temperature management, was removed according to protocol. Echocardiography showed a hypokinetic left ventricle, so we added a dobutamine infusion. In the neurological monitoring, we revealed a reactive baseline with intermittent seizure after rewarming. We treated them with intravenous lorazepam and levetiracetam. When we look on the curve, we first see that this is the right patient. He has no drug allergy and his body weight is at 80 kg. Then we start again with the vasoactive substances. We have norepinephrine with a dosage of 0.1 microgram per kilogram body weight per minute. And then we got the dobutamine, which improves the stroke volume and the cardiac output in a dosage of 2 microgram per kilogram body weight per minute. That should be nearly 2 milliliters per hour. The patient received 2 medications for analgesia and sedation. It's propofol and remifentanil. We have propofol in a dosage of 6 milliliters per hour and remifentanil in a dosage of 0.06 microgram per kilogram per minute. For volume, the patient received lactated solution in a dosage of 21 milliliters per hour and intravenous nutrition, in this case smofcabivin, in a dosage of 84 milliliters per hour. Together that's 100 milliliters, and we need this later for the input-output. Now when we look on the other medication, he received PTT controlled heparin prophylaxis in a dosage of 2 milliliters per hour, potassium in a dosage of 3 milliliters. The patient got also the anticonvulsant substances like lorazepam. He received it later. Because of his seizure potentials, the patient gets the anticonvulsants lorazepam. He will receive this later. And the levetiracetam. He received this at 8 o'clock this morning. As further medication, we set up the aspirin and ticagrelor and a beta blocker, bisoprolol, and a statin via gastric tube. The next step is the monitoring. We have an EEG with no abnormalities right now. He's in a tachycardic sinus rhythm with a high blood pressure. It looks like he's a little bit stressed hearing me talking, or else we need to discuss this with our expert. The SpO2 is in normal range with 92% to 96% under an oxygenation of 35%. He got a normal temperature. Right now he's a little bit high with his heart rate with around 130 to 140 beats per minute. His blood pressure is between 110 and 120 systolically and diastolic with 90 millimeters mercury. The result of the in and output is plus 1.5 liters from yesterday and a normal urine output right now. We check the ventilator settings. He is in a BiPAP mode, inspiratory pressure of 18, PEEP of 6 and the respiratory rate of 16 with a minute volume of 5 liters. The blood gas analysis shows a metabolic acidosis with a pH value of 7.31 and a normal PaCO2. The lactate level is at 2.9, but we came from over 8 millimoles per liter when he entered the hospital. In the laboratory, the only elevated parameters is the PTT, troponin and NT-proBNP, which can be explained by the current situation and medication.
All right. Now you've seen the patient again, and I will start sharing my lecture, which I hope you are seeing now.
Yes, we see the lecture, but in
There.
now in full screen mode.
Now it's in full screen. All right. All right, then. So you've seen the patient, and that is a typical example of a patient post-CPR. He has an anterior STEMI. He has been resuscitated with pre-hospital cardiac arrest. And you will see these patients anywhere in the world or any ICU, and they all look somewhat similar and yet different at the same time. And I will go through how you're going to treat these patients. These are my conflicts of interest. They don't have anything to do with what I'm about to tell you. So this is the case, and why do we actually talk about this? Why do we talk about this kind of patient and this kind of disease and critical illness? So let's go through this number patient, ICU days 1 to 6. If you look at the whole thing, he's on temperature control at 33. He's rewarmed. Actually, most centers do a little bit less, do like a quarter degree per hour, but that's just minor things. So that takes about 16 hours. And if you have agreed, it takes 8 hours. So yeah, that'll take some time. You heard about the TTE with hypokinetic left ventricle. So you might want to consider myocardial stunning there. They started a dobutamine infusion, which is something lots of ICUs do. There's actually, and that's not standard everywhere around in any ICU, there was a continuous EEG monitoring. You saw the little electrodes on the patient's head. And they did some anticonvulsant medication because they saw seizures, and that is something that, of course, can happen in many patients. And we will discuss how you actually evaluate that and how you put that into consideration about prognostication. That will be a big part of what we're talking about. And then if we go to the end of this patient, which we'll hear later, then after 72 hours, the patient's neurologic exam reveals reactive pupils, a positive corneal reflex, and withdrawal from painful stimuli, all things that are actually really good. And after a couple more hours, a day later, the patient starts following commands, and then in the story, he's extubated on day 6. So that's kind of a round story, and we're all happy for Mr. Miller. Is everything done here right? It's a good case. It's quite a typical example, as I said. I personally would do some things differently, but that's just maybe my personal opinion. I'll show you why I have this opinion. Yet I'm unsure that in the end, this is a typical example, given the circumstances under which Mr. Miller reached the hospital. Most patients do a bit more poorly because there is in the patient's history a 10-minute no-flow time. And that usually does not end well for most patients. So let's talk about it. Why is out-of-hospital cardiac arrest actually important in critical care settings? Depending on where you are in the world and depending on what population you look at, we will have 67 to 170 cases per 100,000 population per year. So you'll end up seeing these patients. About 40% are VFib, so a rhythm that can be treated using defibrillation. Depending on, again, where you are in the world, CPR is attempted in 50 to 60% of cases. And in Europe, which I can tell you about, it's better to have a cardiac arrest if you're in Scandinavia or the Netherlands than having one in Germany, Spain, or Portugal, because bystander CPR varies massively and ranges from 13 to 83% of cases. And I personally would like bystander CPR if I drop dead. Also, the AED use is quite variable across Europe, and it is significantly lower than in the US. And we're talking of about 4 to 59% of cases in which AEDs are used. CPR with defibrillation within the first 3 to 5 minutes actually yields a survival, sorry, there's an arm missing, of 50 to 70%. So that's good. Each minute delay, and again, no flow time, 10 minutes, in our case, increases mortality roughly by 10%. So if you want to be the bearer of bad news, after about 10 minutes, most of your patients are actually dead. In-hospital survival after CPR in Europe is on average 8%. So less than 1 out of 10 patients that make it alive into your ICU actually leave the hospital alive. So just saying that, means these are critically ill patients, have a poor prognosis, and you will have to treat them as such. You will have to be very thorough, and you will have to prepare family and friends and relatives of the patient for maybe poor prognosis in your initial discussion about the patient. Why do these patients die? Well, cardiovascular failure is the main mortality predictor in the initial days. Brain damage is the main predictor in 60% of the cases later on. So initially it's shock, later on it's neurological prognosis. And that's what I was talking about the delay of defibrillation and no flow time. That's a really old graph already published in JAMA 2003. So if you delay defibrillation in patients that need to be defibrillated after more than 10 minutes, you have survival of less than 10%. So that's really bad, and that's why we try to defibrillate early, and that's why there are AEDs and guidelines and so forth. And basically, the goal of guidelines, and whether you're looking at ERC guidelines, AHA guidelines, or your national guidelines, is to create this chain of survival. What does that mean? Chain of survival means recognizing cardiac arrest, recognizing a potential situation in which a cardiac arrest might occur. Ideally, you might want to call emergency services before that happens. Then delivering CPR, restarting the heart with early defibrillation, and then optimizing the care after ROSC, after out-of-hospital cardiac arrest has been successfully treated initially. That's what we mean when we talk about chain of survival. And there are a plethora of factors to be looked at. Public health interventions, your healthcare system, psychological factors. So it's really important that you take a look into the guidelines. If you want to break them down, then there are regarding epidemiology, which we might start with, there are 5 main messages. We need to actually get a clear picture of what CPR is actually like. So we all need to do registries. Everybody who's been resuscitated, all their data should go into a national or international registry. If we talk about out-of-hospital cardiac arrest, well, everybody's encouraged to actually take care in the EURECA, European Registry of Cardiac Arrest. There's less data on in-hospital cardiac arrest, so we actually should be getting better and monitoring that. We need to make sure that we gather good epidemiologic data on long-term outcomes. Just for example, we know right now that less than 30 to 40% of the survivors of out-of-hospital cardiac arrest with good neurological outcomes return to their job within the next 12 months. So we're talking about a very severe event. And then, of course, we talk about post-cardiac arrest rehabilitation. If we don't have a clear picture of the epidemiology, how can we improve rehabilitation? We need the data first. The reality is that, well, we're good on paper, and then the reality actually varies. And how you survive and how your survival rates are and how low they might be depends on your rhythm, your age, and again, bystander CPR. And that varies grossly. This is American data, and you can see here cumulative survival rates in different emergency medical services agencies. So different counties, different areas, and they have different emergency services. And you can see that there's a huge variation in overall survival rates, some low as 10%, others high as 25%. So there is regional variation. There's a variation between the services that actually provide health service. There's also, of course, variation according to your age. It does matter whether you're old or young, and there is large variation. And you can also see that the causes of out-of-hospital cardiac arrest vary by age. Of course, there's a difference. If you're very young, then you will not probably have a cardiac cause of out-of-hospital cardiac arrest. So more patients will have asystole, while in the higher ages, VFib and VT and PEA actually kind of pick up, and you have more cardiac origin of out-of-hospital cardiac arrest. Sorry about that. That's just kind of double. If you look at the actual outcome in hospital, then the data is getting better. This is already a bit older, from 2001 to 2009. This is American data again that is showing in-hospital mortality actually dropped, and it dropped by 11%. So that's good. Obviously, we're getting better. Not 70% die, only 60% die. So maybe we are getting better. And then the question always remains, why are we getting better? And also, this is still very high. You know, this is they kind of cheat here with that bar, because it starts, it goes from 0 to 55 with a little break marks there. So 60% is not as low. If you would actually draw the bars up to real height, it would still look very massive. The reason why we're getting better is not cardiology. I can say so. I'm a cardiologist by training and a critical care specialist and heart failure specialist. And PCI rates are not the reason why we're getting better. You can see that from 2001 and 2009 in this data set, there was no difference in the amount of patients actually going to a large hospital. No difference in the amount of patients getting cardiac catheterization, like our example, Mr. Miller, and no difference in the amount of patients then actually receiving PCI or PTCA. So the cardiological part kind of stays stable, yet over the time period I show you there, mortality drops by 11%, and you might wonder why that is. And the reason is that we're getting better in taking care of these patients after cardiac arrest. There are some pre-cardiac arrest factors. We're getting better in the bystander thing in many areas, even though overall there's lots of room for improvement. But in hospital-wise, the reason why we're getting better is optimized post-resuscitation care. In Germany, we have this initiative since 2017. I'm sorry, this is in German, for cardiac arrest centers. What are those? Those are specialized centers that try to fulfill very high standards, have a lot of standard operating procedures, and then get certified by the German Resuscitation Council, where actually auditors come, look at your hospital, look at the route a patient takes, look at your procedures, give you ideas on how to improve and demand a lot of things like ALS training, ILS training for nurses and cath lab personnel, and just go through everything that has anything to do with taking care of these patients. So this is an initiative in the German setting, and there are other initiatives around the world. I can only speak for Germany on this. And there are lots of them. Why? Because this is a ubiquitous problem. There are cardiac arrests everywhere, and if you only have like cardiac arrest centers every 70, 80 kilometers, that will not work for the patients. So this is actually the current map of Germany, and you can see a clustering here. My hospital is actually here at the border to Belgium and Netherlands, and we are a cardiac arrest center. We just got recertified for the 3rd time 2 weeks ago before Easter. And you can see that there are large stretches of Germany where there are no cardiac arrest centers. So there is room for improvement structurally as well. And what do these cardiac arrest centers do? Well, basically, of course, we follow guidelines, and let's have a look at the guidelines and the single topics that the guidelines deal with. You all know this. This is the ALS algorithm, where you have the patient and then you just resuscitate 30-2, and you defibrillate if there's a shockable VFib, pulseless VT rhythm, or you don't, and give adrenaline if there's a non-shockable rhythm. You all know this. Just look into this, train this. There are very few situations in modern medicine that can be trained as effectively as this. Why? Because this algorithm is made for a situation that occurs around the world and is not dependent on a lot of resources. So you can do this even in resource-strained areas. And then if you look at this, well, where do we come to the cardiac arrest center and post-resuscitation care? Well, basically most of the time when there's return of spontaneous circulation and when we consider the causes and the further treatment. So if the patient needs coronary angiography, if maybe he does not have return of spontaneous circulation and there's continuous mechanical chest compression and the discussion about extracorporeal CPR, ECMO CPR, we'll talk about that. And after ROSC to stabilize, like I said, stabilize the shock and then optimize neurologic outcome. So this is where we end up and where we get to the question, well, do you want to be taken to the cardiac arrest center, or where should we take the patient after CPR? And that's post-resuscitation care. That's the main focus of these cardiac arrest centers. And it sounds like much, but actually it can be broken down into a couple of things. First, again, this is the immediate treatment, emergency departments, emergency services, out of hospital, and you all know this. We stabilize going through the ABCDE approach. Our patient, after he has got ROSC, maintain normal oxygen, do the waveform capnography and so forth, get an ECG. That's important because we want to check for cardiac causes. We aim for relatively normal blood pressures, and we start temperature control. I'll go into more detail in a bit as soon as we can, and I'll show you that there's a range between 32 and 36 degrees centigrade that you actually should approach. And then the main question, pre-hospital, or at least when you enter the hospital, is there a likely cardiac cause? What's a likely cardiac cause? Well, that's, of course, if there's ST elevation. Our patient will have had ST elevation because he had an occluded left anterior descending artery, will lead to anterior ST elevation. And if the answer to that is yes, you might want to consider direct coronary angiography and PCI, and the ability to get a patient from emergency services, pre-hospital treatment, directly into the cath lab is one of the cornerstones of post-cardiac arrest care and cardiac arrest centers. If you don't have that, well, you still might consider that if there's a high likelihood of cardiac causes for the out-of-hospital cardiac arrest, like previous thoracic pain, history of coronary artery disease, and history of heart failure, all these things that make a cardiac cause more likely. If there's no likely cardiac cause, you might want to consider other imaging, CT of the brain, CT of thorax and abdomen, to rule out differential diagnosis, stroke, cerebral ischemia, aortic dissection, and so forth. Everything that's the differential diagnosis for dropping dead, basically, out of hospital. If there's trauma, you might want to do that. And there's a whole section in the guidelines about trauma CPR. If you identify extracardiac causes, then you're fine. If you don't, then you end up with coronary angiography again. So you have to kind of go through the patient's findings and make sure you don't miss anything. And in the end, after finding the cause and maybe treating the cause, you admit the patient to the ICU, and that's where all this starts, where we optimize everything to enable recovery for the patient. ICU management then includes temperature control, we'll go into that, maintaining normoxia and normocapnia, sounds easy, protective ventilation. In our setting, the patient was ventilated okay. He was a bit hypercapnic, he was a bit acidotic, tidal volumes were a bit high, protective ventilation, 6 to 8 ml per kilogram. It was a bit over that. We want to avoid hypotension. That's important. We want to do echocardiography. We want to maintain normal glycemia. As we saw in our example, we want to diagnose and then treat seizures. We do EEG, we do sedation, we do anti-epileptic drugs. And then most importantly, we don't want to prognosticate early. So the guidelines are very clear on this. You want to delay prognostication for at least 72 hours. Most of the things that the patients will or might show within the first 2.5 days are quite okay. And that does not mean that a patient seizing on day 1 or 2 will have poor neurologic outcome. So delay prognostication until the first 2.5, 3 days are over. And there are, of course, malignant signs for poor prognosis, for bad neurologic outcome. But again, don't draw any fast conclusions from like an initial CT scan on day 0, 3 hours after being resuscitated or something like that. And then, of course, once neurologic prognosis is clear and hopefully good, we are in functional assessment, discharge, rehabilitation, and secondary prevention. Don't forget that some patients might need an ICD. And so we went through this and we went through that. And basically, if that was all, I could stop here because those are the guidelines and you can read up on the rest. Of course, we will not do that. Let's go through some of the initial things. We'll talk about targeted therapy as the cause of the CPR and optimal critical care. And to begin, when we talk about this, how do I actually now optimize this beyond the guidelines that give me this nice flow chart, which I can read in 5 minutes, and then I might not be wiser than before. So in the beginning, we need to talk about what is cardiogenic shock, because if a lot of these patients have a cardiac cause for their out-of-hospital cardiac arrest, then you will also see a lot of patients with cardiogenic shock. How do you find that? Well, you define it first as cardiogenic shock with or without myocardial infarction, and most of the patients will have a cardiogenic shock with myocardial infarction. So it's called AMICS. If you want to look it up in the literature, look for AMICS, acute myocardial infarction with cardiogenic shock. And there are tons of definitions around. Most of them are quite old, so don't really bother with those. Look for more modern ones like this, the SCAI classification. That's a more recent classification where we define patients that are at risk for cardiogenic shock, have beginning cardiogenic shock, have the typical signs of cardiogenic shock, are deteriorating during your treatment, or are in such an extremis that they actually are under ongoing CPR. So they might not have had ROSC in a pre-hospital setting. They're actually trying to die while you're treating them. And look into that because it's a very nice distinction trying to identify patients at risk that are at the beginning of this cascade or that are further down this very deadly syndrome, because cardiogenic shock is not a disease itself. A lot of different diseases can cause cardiogenic shock. Out-of-hospital cardiac arrest with myocardial infarction is just one of them. So look into that, and you'll find that there's a combination of clinical findings that you might find, of laboratory findings that you might have. You see lactate of 2 here, lactate of more than 5, and of hemodynamic parameters. And you will see, well, it's not just blood pressure. So of course, blood pressure is one thing, but already in stadium B, you find, okay, Somebody's looking at cardiac index, so that's liters per minute per body surface area. PA saturation, so mixed venous saturation. Obviously, somebody's doing something very invasive here, and you'll find more invasive measurements the sicker the patient gets. So most of the patients will end up not just having an arterial line for blood pressure and a central line for medication. They will end up with more things to actually get a better hemodynamic picture of them. So if acute myocardial infarction and cardiogenic shock are so prevalent in patients that undergo pre-hospital cardiac arrest, then let's look at the therapy essentials of those. Because I told you, shock is the main predictor of dying within the first couple of days. And of course, if myocardial infarction is the main cause, then revascularization is the initial cornerstone of each and every treatment. And that's not new. We know this since 1999, 2000, since a trial called the SHOCK trial that was published by Hockman et al. In the New England Journal of Medicine. And revascularization means, well, if the artery is occluded, please try to revascularize it. And whether you do that with a PCI and a stent, that's what that looked like. And this would actually be the left anterior descent here in our patient. And that's what a cardiology consultant looks like when he's in the cath lab. He's pretty lonely, usually have more people around there. Or whether you do that surgically with CABG, coronary artery bypass grafting, open heart here, left anterior descent bypass using the left internal pulmonary artery, or venous bypass grafting, or radial bypass grafting, doesn't really matter. Point in case is, if you don't revascularize, patients will die more likely, more often. If you revascularize, you actually take care of some of the cause of the disease, and patients are more likely to live. So revascularization is key. And we know this since 1999. Here you can see survival with revascularization, 53%, survival without immediate revascularization, only 44%. That was not significant within the first 30 days, but became significant after 6 months and a year. So no revascularization, very high mortality, bad outcome. And why is that? Well, that is because the myocardial infarction is not just a single event. It's a cascade into something that looks like sepsis and has a sepsis-like disease. So what happens? You get an AMI, and you have a problem with a diastolic and systolic left ventricular function usually. Diastolic dysfunction means that you get congested. Left ventricular and diastolic pressure goes up, which means your lungs get flooded with blood. You become hypoxemic. That increases ischemia that's already present because, well, one of your coronary arteries is blocked. You get systolic dysfunction because your muscle cannot contract anymore, which reduces cardiac output and stroke volume, causing more hypotension, less delivery of oxygen, and thereby increasing ischemia because less oxygen means less oxygen delivery, and coronary pressure, perfusion pressure drops. At the same time, systemic perfusion also drops, and initially you get a compensatory vasoconstriction. However, since a lot of tissue is actually dying right now and is being damaged, you get systemic inflammation, which leads to something that looks like sepsis. You get inflammatory cytokines, you get an increase in INOS, and that creates a lot of nitric oxygen in your body, and that leads to inadequate vasodilation. And you all know distributive shock, septic shock is a shock with inadequate vasodilation, and the later cascade of cardiogenic shock looks exactly like that. However, what's missing? Well, the hyperdynamic left heart is missing because your heart is actually being damaged. And the combination of this, the vasodilation, and the myocardial ischemia with systolic and diastolic dysfunction is the cause of this high mortality, because this circles just down the drain and leads to death if you don't intervene. So it's a SIRS sepsis-like syndrome, high mortality. Even if we revascularize, we're still talking about 50% mortality even today. And in the situation that's been described in our example, with out-of-hospital cardiac arrest, more than 60% of patients will actually die. And that's why we need to treat that, reverse the spiral in which patients die. Why does this inflammation happen? Well, basically, if you look at that, whether it's pathogen-associated micropatterns called PAMPs or damage-associated micropatterns, DAMs, both lead to the same pathway of inflammation. So all of these patients usually have an increased PCT. Our patients did not have that in the setting. Despite having a lactate of 8 at the beginning and a lactate of about 3 on the 3rd day, he would probably have an increased procalcitonin because there is inflammation going on. And it's really hard to tell apart whether that inflammation then is bacterial or just the damaged tissue. So these patients look like septic patients, not just from clinical findings, but also from laboratory findings. So how do we treat that? How do we treat the hemodynamics? What are our targets in these patients? If I say a lot of patients die from refractory shock in the beginning, what do we do? What are the specifics? Well, we do everything. If the patient is impaired in his contractility, you need to increase that. In our example, the patient was treated with dubitamin. If the patient is in a vasoplegia, he needs increased afterload, so they get vasopressors. Our patient was on norepinephrine for the afterload and was on dubitamin for contractility. And if these patients are sepsis-like, then they shift volume. Volume is distributed. It's this distributive shock. So they need preload. They need volume resuscitation, similar to patients with sepsis. And our patient was still on day 3 in a positive fluid balance. I think it was like 1 liter over the last 24 hours or 1.5 liters over the last 24 hours. So obviously he was still in need of volume resuscitation. And so you load with crystalloids. Actually, you do use the same goals you have in the Surviving Sepsis campaign. So you treat them a bit like septic patients. Why? Because the sepsis trials are better in generating evidence for how to deal with volume. You use vasoconstriction, and the first-line drug is norepinephrine. Please don't use anything else, like dopamine. That's way out of the setting because there's no advantage. And please don't use epinephrine. I will show you that, I think, in a couple of slides. Epinephrine in the ICU setting in cardiogenic shock is always associated with increased mortality. And use inotropes for contractility. And in our example, they were using dubitamin. I would rather use milrinone, but that's just personal preference. There's probably not a big difference. They are similar, and some centers use levosimendan, which is also a very interesting drug, but is a bit more pricey, but offers some advantages because the positive inotropic effect is oxygen independent, unlike any other drug. So these patients look like these, and that's a bit similar to what you saw, except that most of them would actually have some invasive hemodynamic monitoring, something like this. So they're difficult because you have the left heart, the right heart, you have ventilation, sedation, nutrition, and by the way, nutrition is really important. Our patient there was on parenteral nutrition. Once they actually stop being volume dependent, you might want to start enteral feeding. So it's everything critical care offers. Everything you're learning in this masterclass is also applicable to cardiac arrest and post-resuscitation care. So you have your normoxia and normocapnia targets on the ventilator. Remember, protective ventilation. You use crystalloids to correct hypovolemia. You have your targets for hemodynamics that are just very broad, like mean arterial pressure of 65. You want a lactate to decrease. You want urine output to remain above 0.5 milliliter per kilogram per hour. You use noradrenaline and inotropes. But most patients are sicker than that. Most patients don't just get better by targeting this. So you want more information. You want to know what actually is the cardiac index. So cardiac output in liters per minute over body surface area, or what is cardiac power? That's cardiac output times mean arterial pressure with a constant, and that should be more than 0.7. You want to know something about oxygen consumption and delivery. So you need to measure saturation, central venous or mixed venous, and it should be above 65. You want to maybe know something about the right heart, because many patients actually have right heart problems. So you want something like right atrial pressure, which is just central venous pressure, CVP. Depending on how sick the patient is, you might want to know something about left atrial pressure, wedge pressure. And you want to know something about right heart perfusion. which means you need a Swan-Ganz catheter, which is pulmonary artery pressure minus diastolic pulmonary artery pressure divided by right atrial pressure. And then you get a constant, or then you get a variable. And that should be actually over 1.85. Anything below is quite bad. And you might want to have volumetric markers like you do in sepsis with transpulmonary thermodilution. So my point is, some patients get better with your initial access or initial setting of, I'll just target pressure and urine output and lactate. A lot of patients won't, because shock is so profound and you need more insight into these patients with transpulmonary thermodilution, and sometimes you're still going to need a Swan-Ganz catheter. So in my ICU, that patient would at least have transpulmonary thermodilution. He comes with lactate of 8. That's probably SCAI shock D, and we would put in an arterial line right away, which would use thermodilution. I'm pretty sure about that. If you do that, remember that you need to understand how that works. So you get this thermodilution, tracer, and so forth. I'm not going to go into detail because I don't want to bore you, but please learn how you use these and what these measurements mean. There's no point in having the device and not measuring it, or measuring it and not drawing the right conclusion because you're unsure on what you've actually measured and how to actually understand or how to interpret the numbers you're getting. There's a very nice paper on that in intensive care from 2016, how you actually do invasive monitoring in critical patients. And that goes for many patients, and that includes cardiac arrest patients with post-CPR syndrome. Sometimes, again, you need thermodilution. Again, learn how to use that. I know not every hospital has that, and only maybe large centers use that. But whenever you want to know something about the right heart, you will have to get a PA catheter. Whenever you want to know something about pulmonary pressures, right ventricular afterload, you will need to do pulmonary artery catheterization. It's easy, and any information on the right heart and right ventricular afterload needs this kind of device. So learn how to use that as well. And why am I being so sincere about this? Because, again, many patients have right heart failure. Even patients with just a strict anterior STEMI, just imagine the situation that the left coronary artery is large, and there's a large proximal occlusion and the large anterior infarction. Then the tip of the right ventricle, including the right ventricular septum and maybe up to the half of the right ventricular free wall, will have gotten the blood from the left coronary artery. So you will have a right heart infarction. And that's actually in about 1/4 of all infarction patients. So 1 out of 4 patients with an acute myocardial infarction has right heart involvement. And that means you need to adapt your therapy to that. Okay, so we monitor. Which drugs do we use? Again, don't use epinephrine, please. This is data from 2016 showing in a propensity-matched analysis that any use of adrenaline, here, second line, is associated with increased mortality at day 90. So it's a bad drug. It's okay for the emergency setting, pre-hospital. It's okay for the CPR setting. It might be okay for certain intraoperative settings. It's not a good drug if you're doing hemodynamic optimization in the ICU, in cardiogenic shock, or in any shock for that matter. It's not a good drug to use. It will probably increase your mortality in the patient. And again, here compared to any other vasopressor, survival probability in this propensity-matched analysis published in Critical Care 2016 is increased. Why is that? Well, because adrenaline reduces the blood flow to all of your abdomen, increasing anaerobic metabolism there, increasing lactate. It increases oxygen consumption in your heart. And so especially if you have a heart that is oxygen dependent on a delivery that you can actually not fulfill because there's a large myocardial damage, you will have negative effects. So again, not a good drug to use. You use better drugs. What are better drugs? Well, norepinephrine is a good drug. Why do we know that? Because there was this large trial in 2010 comparing shock patients in general. And you can see that in these 800 versus 800 patients, there was no difference in 28-day survival, whether I use dopamine or norepinephrine. However, in the subgroup of cardiogenic shock, and that was about more than a third of the patients, there was worse survival with dopamine, better survival with norepinephrine because of the arrhythmogenic properties of dopamine. And since many patients have mixed shock, since then, actually, most centers stopped using dopamine at all, and everybody's using norepinephrine as the first-line vasopressor. And if you don't believe that, actually, during COVID, there was a shortage on vasopressors in the US, and people started using old vasopressors again because norepinephrine was in a shortage. And you can actually see that's a publication by Hannah Wunsch, which is a really good Anglo-American critical care specialist. There was a publication by Hannah Wunsch showing that increased mortality in that time, just the use of different vasopressors. So use norepinephrine as your first-line vasopressor. You can use levosimendan, as I mentioned, as a positive inotropic drug. It's more expensive. It's not easily it can be easily titrated, but it has a long half-time. So when you turn it off, it actually has active metabolites that keep acting in the body. Once you turn it off, you still have the effect. Why is that bad? Well, because it's also a vasodilator. So if you get excessive vasodilation by using levosimendan and I turn it off, the drug will just not leave the body, but will remain in the body and will still be acting. So that might be a downside. Overall, there is some data, like in this meta-analysis here, favoring levosimendan over dibutamin. So look at the guidelines, use levosimendan or dibutamin or phosphodiesterase inhibitors like milrinone as a second choice. All of this is expert opinion. All of this is based on very little data. There are some randomized trials, but those are all a bit inconclusive. Like this one, comparing milrinone to butyrine in Ottawa, single center trial, stopped a bit because COVID was there, 192 patients. They compared patients with cardiogenic shock. Again, these are the inclusion criteria. You see, they are monitored with cardiac index and Swan-Ganz catheters. So most of them are SCAI C or D, and they randomized them to milrinone or dibutamin, and they looked at all-cause mortality in the hospital and some secondary endpoints. And in the end, there was no difference between milrinone or dibutamin, whether that was the primary composite endpoint or in hospital death. And there was also no difference in any subgroup. So just choose your preference, whether you want dibutamin, which is probably a bit cheaper, which is a positive inotropic drug, or use milrinone, which is a tiny bit more expensive, but has, because of the phosphodiesterase inhibitor properties, effect on pulmonary vascular resistance, lowering pulmonary vascular resistance, and thereby optimizing right ventricular afterload. You just maybe use your personal preference. We in my center use a lot of milrinone because of the right heart involvement in a lot of these cardiac arrest patients. So there's no measurable advantage or disadvantage for either substance. Use the one that you feel most comfortable with, but don't use epinephrine. So that's shock therapy. You know, a couple of drugs that you know from any other shock form, a couple of fluids that you know. What's specific for post-cardiac arrest, post-resuscitation care is temperature control. It's essential and it's mandatory. Any guideline tells you you should do temperature control. What does that mean? That means you control the temperature. And that's not just saying that you put a thermometer into your patient 3 times a day. You actually monitor continuously 24 hours a day, and you keep the temperature stable. And for that, you need devices. That does not work with ice packs or cold infusions. You can lower the temperature with those, but temperature control means intravascular control or extracorporeal non-invasive control. How does that work? Well, for intravascular control, you have these catheters, which are just a central line with 2 extra lines in there that actually don't get any fluid inside the patient, but circulate fluid through these cushions here. And these can either warm or cool and then circulate out again. And you can set the temperature and you can set the rate at which they cool or warm. And then you get maximum cooling, maximum warming, or something in between, and you can keep the patient at a preset temperature. If you do this non-invasively, then you have these large vests around both legs and around the thorax of the patient. And you do the same thing. You pump water in and out of these cooling pads and control the temperature. We use this, and most centers do. Again, a bit expensive, but you can control temperature really easily and really well with these special central lines. And that's what the guidelines mean when they say temperature control. Use a device to keep the temperature steady at a preset level where you want it, and lower it, raise it slowly. Why do we do that? There are a couple of publications that you need to know about, and I will show you why we end up at the recommendation that we have now, which is keep between 32 and 36 degrees. There was the first trial in 2002, again, New England Journal, treatment of comatose survivors of out-of-hospital cardiac arrest with induced hypothermia. So what did they do? They took very selected patients. Those were only VFib patients that had very low flow time. Our patient would not have been in that trial because anybody with a low flow time, no flow time of more than 5 minutes was excluded. So our patient would not be in this trial. And then they put the patients in either on to 33 degrees or just let normal temperature run its course, and they called that normothermia. And the 33 degrees patients stayed at 33 degrees for 24 hours, and then were slowly rewarmed to normal temperature using a rewarming of 0.25 degrees centigrade per hour. So similar to what we did in the example there. And if you look at that, then 200-day survival, so half-year survival, was better in those treated with this hypothermia. So more patients survived if they were treated with 33 degrees Celsius for 24 hours than those that stayed normothermic. However, normothermia was not normothermia. Normothermia it kind of implies that these patients had a body temperature of 37 degrees Celsius. They didn't. They actually all developed fever. You can see they went up to 38 or something more, while the hypothermia group actually did go hyperthermic and then was rewarmed. So actually this is comparing 33 degrees for 24 hours versus the natural course of temperature. And most patients after out-of-hospital cardiac arrest develop fever, which makes sense because, as I showed you, it's a systemic inflammatory syndrome that you're talking about, and that systemic inflammatory situation will cause fever. So again, not normothermia. Because of that, they did a second trial, and now they compared 33 degrees actually versus 36 degrees. So now both groups had temperature control. However, the groups are different. As I said before, it was just patients with VFib, and everybody who had a no flow time of more than 5 minutes was excluded. Here, it's patients with any rhythm. They just wanted to include more patients with a suspected cardiac cause. So we're talking about different patient populations. There might be some in there that have a different prognosis because it's not AMICS, not acute myocardial infarction with cardiogenic shock. It's something else, and we just thought it might be that. So you got to be aware of what the patients in these trials are. In this group, since everybody had temperature control, the hypothermia group was hypothermic. The normothermia group was normothermic. So that actually worked. And everybody was happy because now you have a control group that is actually normal body temperature. Because this would be fever, and you see most patients were underneath that. So this is better, methodologically better than the first trial. And if you do it like that, then there is no difference in 3-year survival, not in 6 months, not in, so days after intubation. This is 3 years. There's no difference in the groups. Probability of survival stays the same. So it doesn't seem to matter whether you are 33 degrees or 36 degrees if you have out-of-hospital cardiac arrest with a suspected cardiac cause, like in that trial. People were not happy because there's a strong belief that hypothermia must be better. So along comes the next trial. Targeted temperature management after out-of-hospital cardiac arrest in 2019. 280 versus 297 patients. Now we're looking at patients without VFib. So now we're looking at those that are non-shockable. Maybe those benefit more from it. And you can see again, hypothermia, normothermia, methodologically well done. Most of these patients die. So you can discuss about the temperature here. I think if you take one thing at first from this trial, then here, number 5, as outcome death, we are talking about 84% dying in the normothermia, 82% dying in the hypothermia group, and then cerebral categories 4 and 3. These are patients with severe cerebral damage, and you can see that there's only a few with this severe one, but even 3 is a severe form of hypoxic brain damage. So we're talking about 95% either dead or severely damaged versus some 90% dead or severely damaged. So take along from this trial, if you are out of hospital cardiac arrest without defibrillation because you don't have VFib or VT, your outcome is horrible. 9 out of 10 patients either die or have severe brain damage. And the amount of patients that you rescue is very, very slim. And of course, there was like a little trend to better outcome in the hypothermia group. Some argue that the cerebral performance category 2 is actually also not good because it means you have some form of brain damage. Only 1 are the ones without it. And you can see there's a very slim difference. Since there was no difference in this trial, what do? We do another trial. So again, the TTM2 trial, now 930 versus 931 patients with out-of-hospital cardiac arrest. And again, hypothermia, normothermia, no difference again in another New England Journal trial, and no real difference in any of the subgroups. Doesn't matter whether you're young or old, long resuscitation or shorter resuscitation, female or male or whatever. So where do we end up? We end up with a recommendation that's from 2023 that you should use temperature control, as I've shown you, and that you should target something between 32 to 36 degrees for 24 hours, and then avoid fever for 72 hours. That's the official European Resuscitation Council recommendation right now. I will show you that there are some regional differences, but that's where you end up. So again, similar to, well, use vasopressors and use the inotrope that you're most familiar with, set a standard for your center. And whether that is 32 degrees for 24 hours or 33 or 36, does not seem to make a big difference. Avoiding fever might make the difference. That's the current state and the current opinion. So that's what it means when we look at this flowchart again. Temperature control 32 to 36 for 24 hours. That's where this recommendation comes from, and that's what it means when we talk about that. Again, here, enlarged, prevent fever for at least 72 hours. So we are targeting the cause of CPR. We are optimizing our care to improve survival and neurological prognosis. And we use the temperature control for that. And everything could be fine if there weren't differences in opinion. And you will, once you start reading up on this, you will stumble across these differences. There is the ERC, European Resuscitation Council recommendation, 32 to 36, prevent fever. And that is based on a meta-analysis that did not show any benefit for doing something else, published in Resuscitation 2024. A couple of months before, the German intensive care Society and the Austrian Intensive Care Society and the German Anesthetic and Emergency Medicine Society did a similar meta-analysis, just switching 1 or 2 studies in and out, and came to the conclusion, well, actually, we should do 32 to 34 for 24 hours. So there's a difference between what is recommended in Germany and what is recommended in Europe. We actually follow, in my center, the European Resuscitation Council guidelines and do 36 degrees and then avoid fever. We do not go down to 32 to 34 degrees. But again, choose whichever recommendation you might want to believe there. So it's not one size fits all, and the last word is probably not been said. You do all of this to actually just enable a situation where you can do neurological prognosis. What does that mean? It means that all of this ICU management, all this keeping the patient alive, stabilizing shock, controlling the temperature, doing everything that you do in the ICU to avoid multi-organ failure and early death is there to enable the patient to reach a situation where you can check if the brain actually survived the cardiac out-of-hospital cardiac arrest well. So delayed prognostication, but at some point you need to start prognostication. And what does that mean? Prognostication is a multimodal approach, and it needs time. So all your therapy, again, like most of the time in critical care, is first of all buying time to do other things. And the other things here is the neurological prognostication and neurological examination. Always remember, clinical examination comes first. So does your patient have equal and light reactive pupils? If he doesn't, and one pupil is blown and the other one is small, or both pupils are blown and non-reactive to light or anything, that's a bad sign. So always look at your patient first, and just don't always just trust the apparatus. If you do use machines, what are you using? Well, you will end up doing EEGs. You will end up doing some imaging. MRIs would be the optimal thing. Most centers do CT scans because MRIs take so long and are a bit more cumbersome. In some patients, you might end up doing something called SSEPs, which are just some kind of evoked potentials, and you will do tests on biomarkers, especially NSE, neuron-specific enolase, and something called S100 beta. Both are neuromarkers and show potential brain damage. So reactive pupils are important. Is there some kind of early seizures that you see? That's of course not good, but it's treatable. You should measure these biomarkers day 1 to 5, or maybe day 1, 3, and 5. You need a neurologist to do these because I don't know how to do them, and I've been doing critical care quite for a long time, but I can't do an EEG by myself. And I can definitely not do these somatic evoked potentials by myself because you need kind of a magnetic device to test reaction for a magnetic stimulus in the brain. So I can do the clinical examination, I can do the biomarkers, I can interpret some of the images maybe by myself, but you definitely need a neurologist. You need an interdisciplinary multimodal approach. And again, MRIs are great because they're so sensitive and specific, but they're cumbersome, and so CCTs, cranial CT scans, are more common. And what does that all mean? What does multimodal approach mean? Well, it means that if you have a comatose patient that is not awake at 72 hours or more after ROSC, and you don't have any confounders, and I will go into that in a bit, poor outcome is quite likely if you have 2 or more of the following: no reflexes, no present SEPs, so no reaction to magnetic stimulation of a peripheral nerve, no signal actually appears. If you have a highly malignant EEG, like a burst suppression, spike waves, if you have a neuron-specific enolase at more than 60 at 72 hours, if you have an early myoclonic status, so seizures that the patient does not, if you have on a brain CT or MRI. So if you have a patient that does not react and have 2 or more of the following, poor neurologic outcome is very likely, and you need to prepare the relatives, the family of the patient, and you need to consider what critical care therapies you will still be doing. But you don't do that on day 1 or 2, you start doing that day 3 to day 4 to day 5. We all like biomarkers because their number is either good or bad, and everything else is maybe cumbersome and difficult. So why don't we just use the biomarkers? You need to be aware that any biomarker that you use will have some kind of pitfall and downside and situations where it's not specific and sensitive. For example, NSE, and these are patients that I've treated. Patient number 1, out of hospital cardiac arrest, resuscitated. NSE on day 1 is 110. Woo, that's high. After 3 days, it should be 60 or less. And if it's over 60, that's bad, right? And then it drops, right, quite rapidly on day 2 and 3. Well, why? Because that patient had a cerebral stroke during CPR. which is good because, you know, cerebral strokes are not that bad. If they don't swell, you actually survive this, and you might feel dizzy a bit, and you have to maybe have an unsteady gait, and you need to do some physiotherapy. But this patient had good neurologic outcome. So don't just look at day 1, look at the course. Patient number 2, out of hospital cardiac arrest, cardiac shock. He's on some kind of impeller device, which is a device that maybe some of you know. It's a device to unload the left ventricle, so improve heart function by pumping hard blood out of the left ventricle into the aorta. What does that do? Well, it creates hemolysis because it goes up to more than 90,000 rounds per minute. NSE is increased if there's hemolysis. So this patient had good neurologic outcome. Patient number 3, in hospital cardiac arrest. We put him on ECMO during CPR because it was a CPR for pericardial tamponade. NSE is over 80 each day. Does this patient have a brain damage? No, he's actually awake. We extubated him. So we put him on ECMO, extubated him. He still has this because of hemolysis. And then patient number 4, no flow time of only 4 minutes. NSA day 3 is 40. He still has diffuse hypoxic brain damage with a severe Lance-Adams syndrome. So he will stay comatose. He will not even reach minimal conscious state. So he has poor neurologic outcome, even though the precondition was not that bad, with a no flow time of 4 minutes, and NSE on day 3 was low. You still might end up with a situation where your brain did not come out well out of being resuscitated. So take this as a piece of the puzzle, not that just as the solution to the puzzle itself. Imaging might be difficult to interpret. I've said that. Talk to neurology, talk to neuroradiology. Often you see thalamic injuries and damaged stem cell ganglia. So you might not see the full-blown hypoxic injury damage, but you see something in the brain stem and again in the thalamus, and that will cause sometimes patients to not wake up anymore. You can see the EEGs. It's interesting to look at that. It's really difficult. I will always need a neurologist. Good luck with that on your own. You need a good neurology. They do the EEG. They do the interpretation of the EEG. So you need a neurologist. And SEPs, I wouldn't even know how to use the machine by myself. So, you know, when you put a magnet here and then you stimulate nerves and you measure the cortical response of your brain, that's really, really difficult. You need a neurologist. Also, you need to know that, again, H-test has limitations. So if this is not measurable, then poor prognosis is very, very likely. If it's measurable, it does not mean that you have good prognosis. It just means that there's a reaction to a stimulus in your brain. Does not mean that you will wake up. So it's a bit like D-dimers. If D-dimers are positive, does not mean you have a pulmonary embolism or a thrombosis anywhere. If they're negative, though, you probably don't have deep vein thrombosis or pulmonary embolism. So this is the flow chart. So keep in mind, it's a puzzle. It's a puzzle that takes time. It's a puzzle that takes a lot of work and that needs an interdisciplinary approach. You will not be able to do that by yourself. You need people to help you, and you need high expertise. And again, if you have this here, no reflexes, no SEP waves, then poor outcome is very likely. If you have 2 or more of the following on day 3 or 5, poor outcome is also very likely. If you don't have that, well, then it's indeterminate, and then you need more time. So use this multimodal approach. New biomarkers are on the horizon, but they also may need time. All right, last couple of slides. Can I add something to this mix? So this is the basics. What else can I do? Some things that I like. Choice of sedative might be important. Our patient was on remifentanil or propofol. That's the standard in many ICUs. Our standard is something different. We use inhaled sedatives whenever possible. Why? Well, because they are taken up by the lung. Their site of action is the brain and your neural cord, and then they are exhaled by the lung. So they're completely independent of metabolism and renal excretion, which is great. So they inhale, work, exhale. So inhaled sedation is exhaled sedation, and that's why we use it, because it's independent of multi-organ dysfunction. How does that work? Well, we just deliver it by a certain device, and I will show you how that works. And we don't use benzodiazepines. The patient there was getting lorazepam for seizures. probably we would give something else like valproic acid or levetiracetam in combination, because benzodiazepines are associated with very prolonged awakening, and they are a confounder for your neurologic examination. Also, propofol is associated with prolonged awakening and less spontaneous breathing. This is actually a trial from our hosts here in the University Center in Saarland. They are Andreas Meiser, which you also will or have heard during these talks, was the PI on this, and they did a comparison in patients using propofol versus isoflurane, and propofol was inferior on day 2 with faster wake-up reaction using the inhaled sedation here in pink when sedation was turned off. So that is probably something that is beneficial in the given setting, and this is how it works. This is a little device. You put that into your respiratory circuit instead of a heat and moisture exchanger, instead of an HME filter. You put this little thing in, which is an HME microbial filter, and then has this reflector where the fluid, isoflurane, is being dispersed by the airway flow, by the oxygen and airflow into a gas-like form, and then is inhaled by the patient. So you have this inhaled sedation without using the large machines that you maybe know from operating theaters. It's an evaporator rod. A lot of it is then reabsorbed, so it's actually quite convenient and quite ergonomic, and actually also quite well budget-wise. So it's not really that expensive. It's actually at the same cost as using propofol. There's some data that this is good out of hospital cardiac arrest, targeted dementia management, and isoflurane. So there is less invasive mechanical ventilation and length of stay in the ICU. So there's patients that do well neurologically leave your ICU faster. That's what this publication from Kranich in 2017 showed. You can see here that the patients had a significantly less stay on the ICU. So in median, the patients with IV sedation stayed about 2 weeks on the ICU, and the ones with the volatile inhaled sedation a little bit more than 1 week. So that's a huge advantage for those that do neurologically fine. There were no downsides in this trial, especially hypercapnia was a bit increased, but that was manageable by airway. Anything else was similar. There is again the time that they spent on the ICU less. In mean, there was a difference between 4.5 days and 98.5 hours less on the ventilator. So probably those that do well and that manage to get extubated are patients that then leave your ICU quicker if you don't use propofol, if you don't use benzodiazepines, if you maybe use inhaled sedation. There's some more data here. They used sevoflurane as an inhaled sedative, and they also showed that this was maybe beneficial, but that's not really standard. Most centers use isoflurane, and they could show that there was less delirium in the patients that were on inhaled sedation, which is also something that can confound your neurologic examination and will lead to longer stays on the ICU. Okay, so you do the shock treatment, you do the temperature control, you have an approach for neurologic examination and prognostication. You might add beneficial forms of sedation like inhaled sedation to the mix. What about these machines that we all talk about in the ICU, ECMO, ECPR? Don't we need to talk about that? And these are the last couple of slides. Yes, you do need to talk about that, because for some patients, drugs will not be enough. This is the picture from before, and you can see now there are 2 more machines that we need to talk about. This is an ECMO machine, and this is an Impella device. And we need to talk about how we use those in post-resuscitation care, because this is important. We do that in patients that might not reach these goals, that are where we are not able to achieve these goals, and that might die if we don't that. And we probably will be using less ECMO in the future and more of this, and I will show you why. I'm not quite aware whether you had ECMO already in this course or not, so just a short recap. What is ECMO? ECMO is basically just a machine where you pull blood from the body, put it through a membrane that puts oxygen in, carbon dioxide out, And then depending on where you put the blood back, you either just get pulmonary therapy. If you drain the blood from a vein and put it back into like the internal jugular vein, into a large vein, you get a kind of a pre-pulmonary lung assist. Or if you put the blood back into an artery, you get, in addition to lung assist, you get a heart assist, because you completely bypass the right heart, the lung, and the left heart. So when we are talking about cardiogenic shock and resuscitation, we are talking about VA ECMO, out of the vein, through the oxygenator, into the femoral artery. That's the basic de facto standard. We bypass heart and lung, and that's what VA ECMO is all about. Is that good? Well, you might have seen these pictures, you know, that's patients being resuscitated out in the street, being put on ECMO somewhere in France or in the Louvre in Paris. So obviously people are doing that. And there's the question, does that work and is it good? I will show you a short overview of 3 trials. This is one trial called the hyperinvasive trial in Prague, 124 patients going through eCPR versus standard of care, and a second trial, 70 patients versus 64 patients, 70 on eCPR, so ECMO while they are being resuscitated versus standard of care. Both are highly published in JAMA and New England Journal of Medicine within the last 2.5 years. Those were patients that were between 80 and 65 or 18 and 70 years old, with either suspected cardiac arrest or with VFib VT, and no ROSC after 5 or 15 minutes, respectively. And they were patients that were all witnessed, so non-cardiac cause and unwitnessed cardiac arrest were exclusion criteria. So somebody had to see you drop. You were not just found somewhere dead. Somebody saw you drop dead, and no flow time was short. They did not have severe comorbidities like severe COPD, terminal heart failure, severe peripheral vascular disease, or metastatic cancer. And the expected duration until ECMO was started was less than 60 minutes. So very selected patients. Witnessed arrest, short resuscitation time before you decide to put them on ECMO or not. And so what happens when you do that? And please first note that these trials take long. So the Prague trial took 7 years, and the second trial here took more than 4 years. So what happens when you do that? Well, you end up with something that is a bit disappointing. The primary outcomes were patients that survived with minimal or no neurologic impairment at 180 days. And there's a trend to being better at the Prague trial, 39 versus 29 patients, but it's not statistically significant. And secondary outcomes were statistically significantly different. However, you can't really take that into account because the primary outcome did not differ. And in the New England Journal trial here by Sovereign, the second trial, there was actually no difference in outcome, primary outcomes or secondary outcomes. So obviously there's no difference that's being proven here, that this improves survival with good neurologic outcomes. And what does that mean? Well, let me break it down for you. We have 2 trials that show that this is numerically but statistically not better. It remains somewhat unclear, if you want to do this, which patients actually benefit from this. We all have patients in our minds, all of us that do these kind of therapies, and we do that in my hospital as well, which we are sure of that they would not have survived if we hadn't done it. However, to keep this up, you need extreme overhead and infrastructure efforts to actually be able to do that 24/7, 24 hours a day, 7 days a week. You need to have a small number of fitting events into even smaller numbers of survivors. What do I mean by that? Looking at that Prague trial, because it's the biggest, that happened between March 2013 and October 2020. In Prague, they had 4,345 witnessed out-of-hospital cardiac arrests in these 7 years, in a city of 1.3 million inhabitants. That's actually 6% of the out-of-hospital cardiac arrests that happened. 1 every 10 days met the inclusion criteria, and only less than 1 of 3 benefited from that. So if you calculate it down, Keeping this up over 7 years, 24 hours a day, 7 days a week, 365 days a year, saves 1 patient per month extra in a city of 1.4 million. And that's a political decision. For that 1 patient, that's great. But you need to remember what else can you do with that resource. So that's a decision every healthcare system has to come up with by themselves. But the numbers are actually scarce, and it's a very selective process to put patients on ECMO during CPR. What about those without ongoing CPR? Just shortly, 1 trial. That's the most important one, the ECLSAT shock trial, also published in the New England Journal in 2023. Those are patients with acute myocardial infarction and shock. Actually, a lot of them underwent resuscitation, but had ROSC. These were very sick patients with a lactate more than 3, systolic blood pressure less than 90, which were planned to be revascularized. Their resuscitation was less than 45 minutes. Their acuteness was not subacute, and they did not have any other disease that ruled out being put on ECMO. So our patient would have actually, if he had come to our center or maybe other centers, would have been randomized in this trial because he met inclusion criteria. And then they randomized 200 versus 200 patients to either go onto ECMO or not go onto ECMO, and looked whether there's a difference in 30-day death rates and a lot of secondary endpoints, which I will not go into detail. What kind of patients were in this trial? There were a lot of SCAI Shock C and D patients. Our patient, because of the high lactate, might have been SCAI Shock D. There were a lot of resuscitated patients. They were sick, pH of 7.2, lactate of 6.8. So a lot of ST elevation, myocardial infarction patients. So patients like our example were in this trial. And a lot of them, again, were resuscitated. 77% of patients underwent resuscitation due to out-of-hospital cardiac arrest before being included in this trial. However, and I will show you what that means, a lot of them did not have unloading or did have any mechanical treatment in the... And if you look at that, if you put patients like in this trial early on ECMO, then you don't improve anything. The 30-day mortality rates were the same. The curves here, the Kaplan-Meier survival curves, are not different from each other. So there was no beneficial effect in this trial, with 77% of patients being resuscitated to be put on ECMO as a standard therapy. I'm not saying that you should not put anybody on ECMO. I'm just saying that putting patients on ECMO just because they are in shock, just because they have been successfully resuscitated, will not yield better results than not doing that and maybe picking the ones that actually need it. So there's no overwhelming evidence for ECMO as a first-line therapy. And that, again, these subgroup analysis did go for anybody that was in the trial. There was no subgroup that actually benefited better from ECMO than controls. And we can just go through this quickly. Okay, so again, this trial for the things we're talking about is important because more than 2/3, 3/4 of the patients actually were post-cardiac arrest patients. Again, they actually had good neurologic outcome. Only less than 25% died due to neurologic impairment. There was no left ventricular unloading, which I will tell you. So ECMO cannot and should not be standard of care, even if in this very sick patient group. Then there's a second trial, which you need to know if we talk about advanced therapies for cardiogenic shock and post-resuscitation. That's the DanGer Shock trial. Also, patients with infarction and shock, with a bit less lactate, 2.5, with vasopressors and impaired left ventricular function. So again, our patient could have been included in this because he did not meet the inclusion criteria, except for he was comatose. So this trial, even though it's a shock trial for myocardial infarction, had a very significant exclusion criteria. Everybody who underwent resuscitation and was comatose after return of spontaneous circulation was excluded. What does that mean? Well, they randomized these patients, 179 versus 176. They looked at 180-day all-cause death and a bunch of secondary endpoints. But many of these patients were awake when they were randomized. Resuscitation before randomization, not 77% as in the ECMO trial, but only 21 versus 18%. And intubation before randomization, 19.6 versus 15.9%. So most of these patients were awake and could talk to you and were not intubated at the moment they were put in that trial. So our patient, Mr. Miller, would have been excluded from that trial because he was intubated and comatose after successful out-of-hospital cardiac arrest resuscitation. These patients were still very sick. You can see they have SCAI-C, D, and E. They have lactate. And during the course of the treatment, let me show you that, they all get intubated. So in the end, 74 versus 66% of the patients are actually on mechanical ventilation. But in the beginning, they are very different from that ECMO trial and very different from the patient you just saw. In that population, again, some of them are resuscitated. None of them are comatose after out-of-hospital cardiac arrest. If you put these patients on this Impella device, which again sucks blood out of your left ventricle into the aorta and kind of unloads the heart because the heart cannot pump, then you get a much better 180-day survival. You can see the blue curve here. Standard care alone is worse for death from any cause than this Impella device versus standard care, the kind of beige curve. And that is statistically significant with a relative risk reduction of 26% for this primary end cause point and a 28% relative risk reduction for this composite endpoint of the trial. What does that mean? It means all subgroups benefited, whether you're male or female, young or old, lactate was high or less high, and so forth. Everybody kind of benefited, but again, none of these patients were comatose after out-of-hospital cardiac arrest. And again, any therapy that brings in big machines like this one is associated with downsides. So even in that population, there are downsides. And what are the downsides? There's a number needed to treat to avoid death of 8 patients. So for every 8 patients I treat, 1 survives. However, there's also a number needed to harm. For each 6 patients I treat, I create 1 extra patient with vascular problems or bleeding. And again, these populations between that ECMO shock trial and this Impella danger shock trial are very different. Again, only 22% of the danger shock underwent CPR, and none of them were comatose. So we don't really know if that kind of device that is beneficial in a cardiogenic shock population is also good in resuscitated comatose patients. We don't really know. We don't have any data on that. So that being said, you end up with this flowchart again, which we've talked about. We've talked about this: ICU management, temperature control, shock therapy, normoxia, normocapnia, prognostication. And if you want to break it down, then there are these top 5 messages that are a bit resource independent and can be done everywhere. Use the ABC approach after ROSC. Do catheterization, so you're vascularized whenever it's possible. Do the targeted temperature management for in-hospital and out-of-hospital cardiac arrest who are comatose after ROSC. Use a multimodal neurological prognostication. I showed you that. And then assess physical and non-physical impairments. We did not go into detail for that before you discharge the patient into rehabilitation. And if I were to add a 6th item, I would add in between here the cath lab and the temperature management and the prognostication. Treat shock. Most of the shock is cardiogenic. Some of it is combined cardiogenic and post-CPR shock that looks like sepsis. Come up with an standard operating procedure for your center, for yourself, how you do hemodynamics, how you actually optimize shock. And then you will end up with some patients that might need ECMO and or this Impella device. The 5 cornerstones that are in the guidelines, those are applicable for the majority of patients. So if you consider these, then you're always on the safe side, and most of the patients will receive somewhat optimized care after out-of-hospital cardiac arrest. And with that, I'm open to any of your questions. Thank you very much.
if there are no questions, there are some in the chat. The first one, if you use an inotrope, can you combine dobutamine and levosimendan, or is it either one or the other?
Yeah, good question. You should not combine them. There's no advantage to giving more than one inotrope. So our standard would usually be the following. We would use a short-acting inotrope like dobutamine or milrinone in the beginning, while these patients are severely vasoplegic, because they are short-acting drugs. I turn them on, they work right away. I turn them off, they stop working. And once the initial vasoplegia has subsided, or has not occurred at all, then we give levosimendan to those who remain in low output. And for that, you need echocardiography and you need some kind of hemodynamic monitoring, but we would not combine. We would switch from the short-acting to the longer-acting / more expensive drug once the patient's vasoplegic shock has stabilized.
Okay, the next two questions are kind of in the same direction. Considering the bad ecological impact of inhaled sedatives, how do you justify using these commonly instead of as a backup?
Okay, so again, that was about
The inhalation as a sedative.
inhalation, genau, but because
Yeah.
of environmental concerns.
Yes, yes.
Yeah. Actually, that's a really good question, and that always comes up when I or Andreas or anybody talks about inhaled sedation. First of all, the amounts you use are very, very low because you have more than 90% reflection of the sedation you need. Second of all, you don't do narcosis, you don't do very deep sedation, you target light sedation. So in isoflurane, you have a MAC in the OR of 1.2, depending on your age. You know, older patients have a little bit higher, younger patients have a little bit lower. But let's say the MAC for isoflurane that you target is 1.2, meaning 50% of your patients in the OR are non-reactive to a standardized surgical incision at the beginning of surgery in the absence of anything else. In the ICU, you use this as a sedative, not to do the setting of an OR. So you use very little, you reflect a lot, and so the environmental impact is low. You also absorb this, so it does not just go up into the atmosphere, it's actually being scavenged in a kind of device that scavenges it. Of course, that then is most of the time incinerated. So there is an environmental issue. However, nobody looks at CO2 production. So what's the environmental imprint of having 20 propofol syringes over the course of 5 to 10 days? What's the CO2 footprint of that? I think that's a kind of a biased approach. I know that inhaled sedation has been on the brink of being very scrutinized in the OR. In the ICU, I think it's a valuable tool, and I think the environmental footprint of this halogenated gas is rather little because we use very little of it.
Then next one, should I check the NSE level in the first day after ROSC to have a baseline and reference, or should the first measurement be after the third day?
Yeah. So most centers either do day 1, 2, 3, 4, and 5, or day 1, 3, and 5. You should get a baseline. Don't draw any hasty conclusions from the baseline. However, if your baseline is 500, then something's wrong. If your baseline is 20, something might become wrong. But yeah, get a baseline. I would recommend that.
So then another one, how often is the Lazarus effect seen in out-of-hospital setting? Are there any studies?
I'm not aware of any pre-hospital studies on that. But again, I'm not the pre-hospital emergency department specialist, but I, to my knowledge, don't know any studies on that. No.
And then one last one in the chat. Our patient was treated with bisoprolol and dobutamine. On the surface, this is counterintuitive.
Yeah, it is. I wouldn't do that. So there might be a setting where you give beta blockers to shock patients if they have recurrent ventricular or supraventricular arrhythmias. Then you might consider that. Amiodarone would be the drug of choice first line because it is not negative inotropic and so forth. Yeah, I would not do that. I would not put the patient on dobutamine and norepinephrine. Have a patient that's obviously, that's the example, still volume, being volume resuscitated. Lactate is a bit high. He was still on the plus side of getting fluids, and then have a beta blocker in there. You would not do that. Completely right.
I think, yeah, there's another. Oh, okay, 2. Are there any negative consequences such as thrombosis, associated with the Thermoguard central venous catheter?
Excellent question. Potentially, yes. More in patients who get the device because of refractory fever. So sometimes you use it in a patient that's septic and has like trying to fry his brains and has a core temperature of plus 40 degrees, and you can't get medically controlled. You might use it there. And there we see an increased rate of thrombosis. The thing is coated with heparin, which of course, if you get a problem with HIT, you might want to remove that. In the short time that we use it in the patient's post-CPR, we actually don't. The device, it can stay in place for up to 7 days that I showed there. After that, it's off-label. Some centers use it longer because it's quite expensive. At least in the German market, the initial setup, need the consumables for the device plus the catheter probably ends up to be 800 to 900 euros per patient. So it is an expensive therapy, but it is very effective. But increased thrombosis, more likely if you use it to treat very high fever. So somebody said sustainability in medicine. Yeah, absolutely true. Podcast. And actually, if you want to look onto environmental footprints, there are many more things that we can do, and we should not be talking focused on inhaled sedation. Go to the website Green ICU. It's a Dutch website at Corona ICU, which is great. And they did a trial. They did a really big publication, and they show the environmental footprint of critical care. Excellent website. Look into that. If the patient has permanent AFib, probably, and cardiogenic shock, would you still stop beta blocker still? Again, if he has AFib, put him on amiodarone, do an echo, do hemodynamic monitoring. If it's low output, use an inotrope. I would use milrinone because it does less atrial fibrillation. And remember, the permanent therapy for arrhythmias is electricity. So please remember to cardiovert your patients. And there's a question, heparin versus enoxaparin in the ICU. Good question. In a general ICU population, there is no benefit for using unfractionated heparin. There's actually a New England Journal trial a couple of years ago, long before the pandemic, showing that low molecular weight heparins are better in a general ICU population. In the post-CPR population, most centers actually use unfractionated heparin because you're quite unsure about renal function and so forth. And you have antiplatelet therapies, and you might want to have something that you can stop and antagonize if you stop it. So standard is usually unfractionated heparin. Most patients, if they don't have arrhythmias, supraventricular arrhythmias, just need thromboprophylactic doses, which is like 400 to 600 units per hour, probably. Our patient was on more heparin, which would be an effective, PTT effective dose, because I think he was getting like 1,000 units per hour. Yeah. But in a general ICU population, enoxaparin is probably safe and effective and creates less HIT, probably good. Combination vasopressin, norepinephrine, excellent question again. I think the evidence for norepinephrine, for vasopressin is getting better. There was just recently in the beginning of March, and the opening session of the Intensive Care Medicine Congress in Brussels, they presented a very well-made artificial intelligence trial on indications for vasopressin. Just go read that up. And we use it. And I think the evidence for vasoplegic shock in sepsis is getting better. So many centers are actually switching to earlier use of vasopressin once you have sepsis and you go beyond 0.1 mic per kilo per minute. Just be a bit cautious in the early phase, right after the myocardial infarction. There is some data suggesting more limb ischemia in that setting. So be safe to use a good dose, something by like 0.03 units per kilo per hour. So yeah, but we combine it. If the patient is very vasoplegic, we put in vasopressin as the second-line vasopressor. And then there's a third-line vasopressor that's on the market that is actually kind of generating steam, which is angiotensin 2 as a vasopressor, at least for sepsis and septic shock, but that's very, very expensive. If my IDSU doesn't have active temp control available, should I use preemptive medications to prevent any fever? Good questions. Of course, you can give paracetamol to prevent fever. You'll just not be exact. But yeah, if you're in a resource-strained situation and you don't have that, sure, use drugs, paracetamol, topic cooling, sure. But again, the guidelines actually suggest and kind of demand that if you treat these patients, get a device.
Okay, I think there are no further questions. Then thank you for the great presentation.
Thank you. Thank you for the interesting discussion.
Yeah, and we see you all at the next session.
Enjoy. Bye-bye. Have a good evening everywhere.